You're listening to Physician Non-Clinical Careers, episode number 332, How to Find Fulfillment and Flexibility in Your Non-Traditional Job. Interview with Dr. David Feig. Today, I'm interviewing a podcast listener who has gone through many of the experiences that I know that you have. Because his story is so common in many ways, I thought it would be instructive and inspirational to hear how he has navigated his career journey so far. Before we do that, however, let's hear from today's sponsor. This podcast is sponsored by the Physician Executive MBA program at the University of Tennessee, Knoxville's Haslam College of Business. In less than one calendar year, this program will equip you with valuable business acumen and leadership development not found in the traditional medical school curriculum. Are you ready to join the longest running physician-only MBA program in the country and a network of nearly 1,000 PEMBA graduates? Contact Dr. Kate Atchley's office at 865-974-6526 or go to nonclinicalphysicians.com/physician MBA. By the way, did you know that you too can sponsor the Physician Non-Clinical Careers podcast? As a sponsor, you'll reach thousands of physicians with each episode to sell your products and services or to build your following. Your message will be heard on the podcast, seen on our website, in our newsletter, and on social media posts. So to learn more about that, go to, or send an email rather, to john.jerica.md@gmail.com and include sponsor in the subject line. Dr. David Feig completed his medical degree and then his master's degree in public health at Emory University. Then he completed a family medicine residency at the University of Michigan, followed by a sports medicine fellowship at Rush University Medical Center. He worked about 4 years before branching out into chart reviews and part-time medical director roles in various settings. He also tried locums and telemedicine along the way. In his most recent job, he is reviewing claims as a Medicare contractor. In today's interview, he describes his journey and his thoughts on the different jobs he has tried since leaving clinical medicine. All right, let's meet today's guest. I invited today's guest because I think he represents many of you. He practiced medicine for a while, decided to try some other things part-time and full-time, and he tried locums, he tried telemedicine, and recently he's been performing claim reviews for Medicare. So I'm really interested in hearing what he has learned from all these jobs he's done and what advice he has to share with me and with you. So welcome and hello, Dr. David Feig.
Hello, John. Thank you for having me today.
I'm really glad you agreed to do this, because again, because so many of us kind of reached a point where we thought, well, maybe I should do something else, or for whatever reason, we maybe get into your reasons today. And then we just kind of look around and try different things, sometimes part-time, sometimes full-time. And so I think it's just going to be really interesting to hear what motivated you and what you learned along the way. So thanks for being here.
Again, my pleasure. I was a listener before I became a guest.
Yes, and that's a good way to go for me because then it's so relevant to the other listeners. I think to hear your perspective. But tell us a little bit about your early, education and your clinical career. Before you started thinking about making a change.
So I guess I kind of had a little bit of an atypical path to medicine in the sense that, I went to college. I was pre-med. I was kind of like thought, oh, I'm always going to be a doctor. Growing up, I had a very gifted pediatrician who took very good care of me and my brothers. And he was definitely an inspiration. I think, just as an aside, I guess he was trained clinically as a neurosurgeon, but
Interesting.
apparently he had some issue operating. Like back in the day, I guess the way they did lighting in the ORs, it gave him sneezing attacks. And obviously during brain surgery, that's a big problem. And I had to retrain essentially in pediatrics because he couldn't operate. But that level of skill translated into his pediatrics. He was quite brilliant. And he always, had a moment to answer my questions, and he was very much a great role model for me. So I guess over the years, I tried to talk myself out of doing it, seeing how hard he worked. But then I thought, well, I need something that's going to engage me. So went off to college and was in the pre-med track. And I guess I tried to distinguish myself by trying not to be as cutthroat as, the stereotypical pre-med
Mm-hmm.
student. And I guess it had some moments. And I went through my training. And since I was going to go to medical school, I thought I'll major in English. Why not? Why not be different? But then
Mm-hmm.
I'm like, so I double majored in English and biology. So I did that for a bit, and I had already had notions of taking a year off. So I was going to take a year off. My mistake was looking back on it was, what was I going to do in that year off? Because if you're looking for a job, a lot of places are like, you're going to go in a year and start school, and not a lot of
Mm-hmm.
places are excited to hire you in those scenarios. So I was able to get some work, and I did apply to medicine. And I think for my first application cycle, I was very ill prepared in terms of where I applied. I applied to a bunch of very selective schools. Maybe I was a little overconfident. Who knows? I think I got two interviews and one wait list, and it didn't work out. And I'm like, oh, this is terrible. I didn't get in. What am I going to do? And I applied one more time. This time I was a lot more broad in where I applied, and I got like seven. I'm remembering, but I'm pretty sure I was on seven wait lists. And I
Mm.
thought, seven wait lists. This has got to be made, and I'll get in somewhere. And I had two friends from college who also had gotten, had applied, and they were on one wait list apiece. And they both got off their wait list. So I'm like, great. And then seven became six, and five, and four, and
Uh-oh.
then three, then two, and then I was like, oh dear. So that was definitely a kick in the pants. So
Mm-hmm.
that's when I realized I needed to improve my credentials. So I went back and got a master's in public health with the notion that either I was going to get a job in healthcare if I couldn't be a doctor, or it would be enough to hopefully get me over the hump and an acceptance somewhere. And that it was either that or do a post baccalaureate program, which I'm not sure how much you even remember or have heard of, but essentially it's programs that sprung up to help people that either didn't major in sciences in college, like get extra science credentials so they could apply to medical school. But
Mm.
that's basically all it is. It's a degree that lets you apply to medical school. It's not necessarily training for anything else.
Mm-hmm.
So at least master's in public health would be, exposure to different areas of healthcare that maybe you don't see from the clinician or the physician side. So I did that and I applied one last time. And after some trials and tribulations with two more wait lists, I got offers from both places and everything
Good deal.
started. And it was quite the shock when I finally got accepted because I wasn't sure, they say third time's a charm. And I guess you could totally say that for me.
Well, we have more in common than I knew about, even from talking to you before. And that I was not accepted. I was out for 2 years, and what I did was I took a micro course, because I think that was the area I was weakest in. And lo and behold, when I applied, the 2 or 3 years later, I got in. But who knew? And we both have masters in public health, so that was something I did after I was in practice. But that's interesting.
Mm-hmm.
So keep going. Tell us more now. You've made it through med school, and you did some other. Well, you went into family medicine, but then you did a fellowship after that, from what I know.
Yeah, medical school was definitely really hard for me. And I think it's hard for a lot of people. And, coming from probably very academically talented, most people that go on to medical school have great academic credentials or they wouldn't have gotten in, whether it's the first time or the third time, of course. But in my case, definitely had some struggles. I guess the one footnote maybe to the story that I do get a kick out of later on was at times, I think I caught the ire of some of my professors because of my yawning. I would yawn a lot on rounds, and
Really?
it got enough that it was noticed, and I really couldn't put my finger on it. But it definitely didn't make things simple, I guess what I would say. But I persevered, and I think that was also the year that they had raised the passing grade for the step one exams. So
Mm.
everyone was a little nervous. That's the first year that they made this change. So how's this going to go? And to the surprise of some, I comfortably passed. So I was pleasantly surprised. Not everyone did, but at least I was not in that group. I was in the other group that was like, oh, good. Made it through the last, 2 years of medical school, my clinical rotations, and I wasn't really sure what exactly I kind of wanted to do, which is kind of a story in of itself. But long story short was, at the time, the scramble is not fun. The scramble is very nerve-wracking.
Mm-hmm.
But it's particularly nerve-wracking because this was they had made some changes in the years that followed that made it much more organized. But
Mm.
when I was in it, it literally was a scramble in the sense that you wish you had two cell phones and two fax machines, because for all you know, people are trying to send you offers and you can't get them, and they're trying to call you on your phone, but you're already talking to somebody
Mm.
else. So it was nuts. But after that crazy day, uh, I was truly fortunate that University of Michigan had an opening due to some, things happen in the match. You can't always predict. They had an opening. And my uncle, he used to live in Ann Arbor and he always spoke very highly of it. So I thought, well, Michigan is the place to be. It's a huge school. They must have a
Mm-hmm.
great program. And I was very fortunate to get an offer that I immediately accepted. The goal was always to do something where I could do more sports medicine.
Mm.
And initially, I thought about doing physical medicine and then doing some sports medicine through that, but it didn't work out. So then the next plan B, as they say, was, well, family medicine has very well known sports medicine history. So, get to Michigan, get a fellowship, and then sort of go on from there. So that was sort of everything. That's sort of why I gravitated a bit towards family because of the connection to sports. And that, I was, again, very fortunate that, I guess, as they said, my step two score was good enough to draw attention and help secure. And I guess the interview on the phone probably didn't hurt because they did offer me the spot.
Nice. How was that program? The
Oh,
sports
that
program.
was a breath of fresh air. Coming, I guess, in medical school, depending on the size of your class, it could be 50 people, it could be 100 people. I'm sure there are some schools that have even larger classes.
Mm-hmm.
And, they got to keep tabs on everyone because, if every medical student doesn't go on to residency, then I think that catches a lot of attention to the programs they don't like. So they really want to make sure everyone, gets a residency and goes on somewhere. But then when you're actually a resident, it's not one of 100 or one of 200. It's one of maybe 20 people, a class of 20 or 30, maybe a little more, oftentimes less.
Mm-hmm.
And trying to, I think 24 was the program. I'm blanking on the number, but it was like between 10 and 12 per class per year. And
Mm.
it took maybe a few more interns, and then they recruited some more, I think, for second and third year. I'm dating myself because this was all the way back, in 2003 when I did residency. So that was a while ago, and I'm sure it's changed probably multiple times
Yeah,
since then.
probably
But
true.
it was a breath of fresh air, and a lot of struggles that I had in medical school really, I think, were different in residency. Oh, and then the funny thing is, after getting some concern that I was on call and I was snoring so loud on call in the call rooms, people would pick me up physically and move me to the outside of the call room and kind of lay me by the door.
Uh-oh.
um, Other people began to notice, and then the thought was, you also kind of stop breathing when you're sleeping. Maybe you should get that
Hmm.
sleep study. And I
Wonder
was
what
like,
that is.
oh, get out of town. That can't possibly be. I've been doing this since I was in medical school. And it's like, oh, okay, go get it. So I got a sleep study, and they did diagnose me with very bad sleep apnea.
Mm.
Very bad. And I was the resident that when I was on call, I would carry my CPAP machine with me to the hospital in case I got a chance to lay down for a while. I would put my CPAP on because that way, if I slept, I actually could get restorative sleep for a change.
Well, that adds another twist to trying to catch an hour or two of sleep when you're on call. That's for sure.
And then when you can't get much out of it, if you're, apneic, that's, even worse.
Yeah.
So it was definitely a wake up call. And then everything got a lot easier after that, shockingly. I was
Mm.
doing better on my, the department, the in-service exams got much better, performance on rotations got better.
Ah.
And I think I did reach back out to some folks back in medical school about the discovery. And I think ever since then, they unofficially are like, maybe we should get a sleep study on this medical student. He's not doing great. I don't think they've officially called it the Feig workup, but I would definitely appreciate it.
Ah,
Since I think up to that point, everyone in medical school will hit a wall at some point.
true.
I mean, and we talk about how the people who drop out of medical school is traditionally very low compared to other, graduate school programs.
Hmm.
But everyone, I think, has their struggles along the way. And sometimes I think we all think of depression as being a primary issue, but not all depression is depression. Sometimes depression has an organic cause. In my case, I do wonder how much of my struggle was because of the apnea. So that was
Food for
definitely
thought.
a moment that when I, have had patients ever since then that talk about fatigue and elevated blood pressure and lack of restorative sleep or struggles at work, or other stuff. It's like, well, maybe we should get you sleep study.
It's certainly a
So,
ton more common than we knew 20 years ago.
no, totally, totally. So I did finish up with my family medicine training and I went off to do a sports medicine fellowship. And that was eye-opening, I guess, just in the sense of the nature of the practice and kind of how you want to maximize how much you're getting out of that 1 year to kind of get the
Mm.
skills you need to sort of build forward. And I think, at times it was a struggle because it is 1 year. It's only really 1 year to acclimate in some cases to a new city or a new environment. But all the while, you kind of have to be on your toes in terms of, dealing with a new system in some cases, and then also your professors, the athletes you're taking care of. So it was a very busy year, and it definitely was a long year as well. And after finishing up, I basically decided I had enough of the winter, being in the Midwest for a few years. So that's when I was looking for jobs on the West Coast to get away from snow, at least for a little while. And lo and behold, I did find something, and I was off to the West Coast to try to hopefully escape the Midwest winters that I had gotten used to over a couple of years.
So, what did you find? Was it something that was geared mostly in sports medicine, or was it family medicine too, or something else?
Oh, definitely family medicine. And that was maybe the strange thing as I kind of was going through my fellowship. I had realized that I still enjoy the practice of all spectrums of medicine,
Hmm.
maybe not as much obstetrics, but certainly the primary care component was what I think called to me the most. But I still enjoyed the musculoskeletal part too. So instead of trying to do sports med only, I had gravitated to more traditional practice. And every practice, in family medicine, I think the thing is, everyone does something in family medicine, and we all generally have something that we think is sort of our bread and butter. For some, it's more obstetrics. I think for some, it's more cardiology. For others, it might be more psychiatry based or more mental health based. And then some like to do some sports on the side. So I certainly had a very busy traditional practice. But, in that particular group, it was me who had the sports background. And then we had a orthopedist who had decided to stop operating, so
Hmm.
he was really doing non-operative stuff. So we sort of had a nice relationship, a synergistic relationship that we would sometimes see each other's patients, and I'd ask him questions, and vice versa. Although mostly I asked him questions when I was starting out, and he had to go out and about, and he had patients that needed, say, their synovial injections or their knees or something. I'd be happy to jump in and help out with that. So that was a great initial experience, as my first job out of fellowship.
Nice. Well, how long did you continue doing that, and what caused you to make a change when it no longer was what you wanted to do? I don't
Uh,
have any idea what happened, so I'm all ears.
so it was about 4 years, and I think I had come to the realization that they say your first job out of training is going to be the job where you sort of figure out what you want your job to be. And then,
Mhm.
as with everything, there are always some really good stuff, and then there's stuff that's not so good. Um, and ultimately, working in a big system, carries a lot of benefits in the sense that there's a billing department, there are other departments that can support you, there's a credentialing department, all these things that you can take advantage of. There often are CME that they'll pay for and other benefits that you get from working in a large system. But you also have to realize that you also work in a large system with your other doctors and your other coworkers, nurse practitioners, PAs, everyone that kind of forms the team. Nurses, nurse practitioners, LMPs, CRNAs. CAs, certified nursing assistants. There's so many different people that make up that system. And then also, of course, physical therapists, mental health professionals, psychologists, psychiatrists, the list is practically endless. But you definitely have to be part of that system. And if you say have an entrepreneurial spirit, or you want to maybe spread your wings, or if you're like me and you're also very technical and you get very frustrated by maybe the electronic medical records that you use, and most physicians have strong opinions about it, obviously, you're not really in a position where you can get them to give you your own system. You're going to use what they have, and you can do the best you can within it. But flexibility is not something you get necessarily in those environments. You sort of get the security of working for a larger system. The large system is going to pay your salary. Whereas if you have your own practice, you've got to get a bookkeeper and make sure you get your bills sent out to get paid, usually from the insurance companies. Otherwise, you don't necessarily have an income. So,
True.
having more, I guess, explicit understanding of that kind of trade-off. I think after 4 years, it became a little more clear, just in the sense that you have to kind of find a niche, I guess. And I do very much say that when you're out of training, finding what you want to do can be tricky.
Mhm.
And maybe what we don't do is we don't have enough people out of training really explore a wide range of potential environments. How many people when they were going to graduate from residency had a long talk about how to start your own practice? I don't think I think we talked about it briefly, but a lot of people would be like, why would you want to do that? Or that's way too much of a headache. And I'm sure there are those that are entrepreneurial enough that they'll take the risk, or they maybe have enough financial support from family or savings or some other avenues that they're willing to take the chance of doing it. But I guess I was definitely not that much of a risk taker. Definitely wanted to point out systems and technology and how we used it to be more efficient, but also realizing that doing that in a large system, I think, change is never easy. And I think
Mhm.
change in a large hospital system or any healthcare system is challenging. If we look at how our hospital systems have changed over the years, or even how they changed from COVID, maybe we can kind of realize that that kind of change just is atypical. Usually it takes a crisis like COVID to kind of get things to change. And that was maybe a big thing we'll talk about in a bit, is how much telemedicine changed in that time frame out of necessity, that it hadn't really changed a lot before that, until there was like, okay, people need this care and we have to find a way to do it. And these are the places that are set up to provide that. So, well, at any rate, so all those things go kind of on my mind. And I realized that I did want to make a change. And I had pursued some other opportunities. And I found a job working more uh, partly clinical, partly as an area medical director for an urgent care system. Um, it was based out of Portland, that had opened up some places in Seattle. So it was my first, you could say, I guess you could say it was my first official administrative role. The funny thing is that, and it's the other thing I guess I learned the hard way, when you're a physician working in a clinic, whether you want to be management or not, you are one of the doctors there, you are a provider, which means that other staff will definitely notice when you say or do things. So if
Mhm.
you're not super motivated, if you sort of, if the main system makes changes that maybe people don't love, you're not really one of the workers. You're still part of management because you're one of the doctors. So you have to be careful what you say. And you also have to realize that you might not necessarily, you want to just show up and take care of patients and go home. But I think it's rarely ever that simple. Um, so I certainly learned that you have to be mindful of that when you're in your job. So
Mhm.
now I was in this new job and I was actually officially management in my title, at least. So I got to see patients, also help oversee some nurse practitioners and some physician assistants to kind of run the clinics and kind of keep things running smooth. I guess you have some work on that area yourself, so maybe you have some thoughts on that. But it was a nice transition, I guess, to a different kind of responsibilities. I wasn't trying to see 20, annual physicals in a row anymore. I was really more maybe seeing some patients here or there, recovering for vacations. And I was doing a lot of chart review and just being available for clinical support for the team, and practicing kind of in a different way. But having a more flexible environment, that there was a lot more opportunity but I guess you can say, what is it, the expression about, crisis and opportunity? The kanji characters, I think, are very similar. So
Mm.
you have to be mindful that when you're not in a big system, I think you have to be aware that there are more financial constraints. Well, there are financial constraints anywhere, but maybe in different systems, you may be more privy to them than others. So I got to see how the books of a clinic kind of worked in terms of, how the bread was baked, I guess, for an expression. I might not be using the right one, but seeing how they figure out the accounts, I think, was a valuable insight that I hadn't had a chance to really experience before. So
Now that could be very useful, but I tell you, going from being in, basically a corporate environment and you're basically plugged in and working and doing your clinical, and even if you're supervising NPs and PAs, it's not quite the same as like running a practice by yourself, obviously, where you're 100% responsible for the financials. And so, but you were kind of in this, it seems like an in between situation. You're doing some supervising, but you're also managing your medical director. That was a thing that really I noticed when I got into working in the hospital as an administrator. It's like I had never, well, I guess in my practice I had people reporting to me, but it's just so weird. It's so different when you're in a different environment where they're like, okay, you're my direct report or I'm your direct report, and we're going to communicate in a certain way. And the thing is, whoever you're supervising, you're ultimately responsible for them. So it does take some getting used to.
and it kind of goes back to when you are a medical, clinical provider. Sometimes it's a doctor, sometimes it is a nurse practitioner or a PA. It really depends on the circumstance. If you have that front-facing patient responsibility, I think you still have to be mindful of, how you conduct yourself and how you
Mm-hmm.
function, because patients will see how you respond, and coworkers and other people that work in the clinic will also make note of how you act and respond. And I think you just, maybe even more so in the digital age than it was. I guess I kind of started, we were getting into more the digital age. Phones were starting to get cameras back in the day, but now everything is so plugged in. Is social media is much more of a thing than it was so many years ago. Things that you say and do, I think, you want to be mindful of how you respond. I think the old adage was when you're angry, write a letter, but don't mail it. And
Right.
now it's like you write a text message, but definitely don't send it. Don't send the first draft. Send the third or fourth, and try to
Yeah.
tone it down. But those are sort of like maybe more even leadership training or management training that certainly is more available to doctors now, maybe than it
Yeah.
was back in the day. But certainly communication, I think, very underrated. I think they say MD stands for makes decisions, and it's sort of like, yeah, but sometimes if you're not really being a part of a team, I think that can, cause problems that we don't always, consider until way after the fact. So
Mm-hmm.
certainly, dealing with some of the people I had to work with, I had some amazing nurse practitioners and physician assistants that were super sharp. Some of them were really good at patient care. Some were not so good with using computer systems. So I helped them kind of bridge the gap on that. Some were maybe good on the computers, but maybe interpersonal, they could use some work on health coaching and communication with the patients. And That was something that the company I was at the time was pretty good at making sure that they did as much education for the staff as they could in terms of not just clinical stuff, but also, just communicating with patients. Because, in limited visits, you really want to make the most of the time you have, and kind of reading something straight off a book or reading some very rote kind of instructions may not really help that much if the patient doesn't understand them. And a lot of patients don't want to say they don't understand something. They don't want to admit it. So in
Mm-hmm.
an urgent care setting where you may not see them again, that's really important. So
Mm-hmm. Now, was it at that location that you started getting into the telemedicine, or did that come later?
that actually came later. As much as I enjoyed the opportunities working in urgent care, I had this thought in my brain that having relationship with your patients and having that longitudinal care was actually a good thing, and it is a good thing.
Mm-hmm.
Although looking back on it, I think there are caveats you have to be mindful of too. So I wanted to get into a situation where there was more of a panel of patients that I'd be taking care of. So maybe shift from the acute stuff to more of the continuity of care that I enjoyed. So I made one more shift to a startup that was doing more work in that field, more based out of employer healthcare model, in which
Mm-hmm.
employers actually can have their own clinics that are managed generally contracted by this third party. so that the patients, the employees, can go thinking that they are not necessarily going to the company doctor. It's the company that the company hired to help provide some extra care. And there are creative ways you can manage the finances such that you can provide services, the company can cover it. If it helps with utilization of your primary insurance spending, then it can often pay for itself. So there's some interesting ways around it. I think the market's changed a bit over the years, but that was what it was when I came into that profession. So it was a chance to do primary care, but maybe at a little bit of an easier pace, and maybe also without not quite the same constraints you might have in a traditional clinic that would say bill your traditional insurance. So that was also another education about financing and alternative payment models. Whether you have a capitated model or you have more of a HMO model or a PPO model, and trying to figure out which one you've got that you're dealing with.
What was
So
that
that
situation like? Was it one or two of you in a pod, or was it a large group where it's centralized, where employees were
it
coming
started
from
it
all over?
started out pretty small with only I think two locations, and over time it expanded to multiple locations around the Pacific Northwest,
Hmm.
and then it kept expanding from there. So the growth of the company was pretty huge, and it did go on to do some big things from what I understand. So I learned a lot again, and I was hired to kind of work there as one of the docs. And there were some changes, and I had opportunity to get more involved in leadership again,
Hmm.
which was nice. And I did do a lot more on the technical side, kind of working with the EMR system. Kind of got to see the nuts and bolts of it, and that was sort of exciting and also overwhelming because you realize EMR systems are obviously very complicated pieces of software, and I think we don't realize necessarily that a lot of the reasons why maybe we're not as always happy with our systems as we could be comes down to time and money. Really getting a system dialed into your practice and what you do, I think takes tremendous forethought and time. And not every system and not every leader really has the time to parse over if you want the button on the left or the right when you're clicking something to sign a note, or what do you want in your templates? What do you want in the system? How do you want your e-prescribing set up? Do you want to be able to send electronic consults? Is that even a thing? How do you
Mhm.
send records electronically? Or are you just faxing everything? And the more you dive into it, the more you realize is that it's pretty complicated. And it's sort of why hospital systems have entire departments of people trying to
Mhm.
wrangle this, because it oftentimes has that level of detail because humans are complicated, medicine's complicated, and to translate some of that stuff to the non-physician, but to the developer that's writing the program, uh, these are complicated things that we don't often think about. Um, so I learned a lot from the other perspective about that. That was definitely a great experience and also very much overwhelming in the grand scheme of things.
Yeah, I guess what I'm kind of hearing, and I agree, when I think back, is basically when you're in the outpatient setting, even if it's with a big company that has maybe a lot of money, um, yeah, there's not the resources and there's just not enough of a group of patients and physicians to spend the time and money to customize it like that. So we end up basically adjusting to the EHR, the EMR. And yeah, in the hospital systems, it's not necessarily that much better, but there's a lot more customization. And if you have full-time staff in the hospital every day, all day, like a hospitalist group, eventually they're going to customize it to the point where it's a little more functional than it is when it first is implemented.
Yeah, and I think back in the day, I do recall the whole inpatient outpatient system was a hot topic. And I'm definitely dating myself. And I think over the years, it has definitely changed. But it was amazing how many systems really had no conception of outpatient practice. So almost everything was based on an inpatient
Um,
order sets and labs, and everything was really from that perspective. And then you sort of realize that that's why many big hospital systems at many points had an inpatient system and an outpatient system
yeah.
because they didn't have that level to integrate, which is crazy when you say it now, but maybe it goes to show how far and how long systems had to mature very quickly. I think other professional specialties, not medicine, but law, science, I think they had their own struggles about adopting technology. But medicine, I think, had a very interesting path to try to get to where it is today, the integration of new technology into patient care, which is still an ongoing struggle, but that maybe brings us to the next part of telemedicine.
Yeah. So then what
Uh,
you were about to segue either into the another move or thinking about something else. What was the
well,
next step
I
for you?
was with this company that was doing this employer-based healthcare work, which was a great experience just in the sense of how much I learned. But over time, I had also gotten a little bit frustrated, I think, just with the startup world in general, in terms of just how things operate. And I think personally, that was when I think sort of was at a professional low point in terms of my health. That I think the stress of keeping up with medicine is something that all physicians have to deal with, and actually almost anyone in a professional setting, whether it's a nurse, a lawyer, a doctor, a nurse practitioner, a physician assistant, nurse midwife, almost anyone in the healthcare field or even the non-healthcare field, programmers, developers, anyone that can work on a crunch and have deadlines and often work very long hours with very little rest. I think you all experience some level of burnout. And I think over the course of my career, I certainly had burnout several times. And I think we also fool ourselves into thinking that if we just had time off, it would fix it. And it's like, no, it's usually a lot more complicated. And I guess I should give a little shout out to Dyke Drummond, who I did connect with at different points over my career, that was really one of the first people to talk about burnout amongst physicians and then other health professions in a really solid and very focused way that really try to define it. And it's not something that's going to go away if you take a vacation. It's often something that needs continual active management. Problems have solutions, but you don't necessarily order pizza and make everyone in the clinic happy for a day. It often requires more structural changes. And in my case, I think my best efforts of managing my own burnout probably were not successful. And it's funny that he did a course. Dyke had done another course in Seattle around this time period a few years ago that I was like, I thought I was perfectly happy in my job, and now I realize that I'm burned out despite my
Yeah.
best efforts. I think it also comes down to the fact that you can see 20, maybe 20, 25, 30 patients a day and be kind of exhausted.
Hmm.
Or you could see much less patients, but see each one for much, much longer because you have time to see them. And you can get so deep into each patient that you've basically collected probably the same information from 10 or 15 really intense visits that maybe you did from 20 or 30 superficial visits. Instead
Hmm.
of having maybe one or two problems, now you've got collected maybe 10, 15 problems for each patient that you want to address. Maybe the patient has their own things they want to talk about. So
Hmm.
it's the great thing about primary care, and it can also be the detriment, is knowing when to set limits and boundaries, both for yourself and the patient on what you can tackle. As much as we would love to tackle every problem they have on their mind, you remember the days of the patient coming in with the list. And of course, they're there for a
Hmm.
physical. So you have what you want to take care of because you've got to examine them. Well, they have the 10 things they've saved up for the entire year because the only time they go is for the physical, which we still think that's their time, but the reality is it's technically the doctor's time is for the physical, and every other visit, every other acute visit is probably the patient's time. But and yet that that's sort of the narrative that we've developed, and I don't think it's changed that much now that I think about it.
No, and patients get very unhappy because we're just at odds to some extent if we're going in expecting one thing and they're expecting something different, and that's part of I think that also makes it frustrating. Working with patients who are unhappy because it's not going the way they expected it.
Yeah, and I certainly learned, meeting the patient where they are in terms of what they expected out of the visit is most important thing you can do, I think, because if you stick to your agenda despite the fact the patient's giving you signals, that's not what they want to talk about. You will probably both be unhappy at the end of the visit. And it's okay for the doctor to be unhappy. In fact, we often are. It's rarely okay for the patient to be frustrated because they either won't come back or it will lead to worse things for everyone
Mhm.
involved, my
Yeah.
experience. But at any rate, so having been through that experience, and shout out to Dyke again for all his help, it made me realize I needed to reconsider some stuff. And I kind of thought about it for a bit, and I was taking a little bit of time off because I had to restudy for my sports medicine board exams. Yet, actually, I'd taken some time off already to retake my family medicine boards, and then I had to retake my sports medicine boards. And so I was doing that, and that sort of had that thought about maybe moving on to something new. And I think the company was also thinking that maybe it was time for me to explore some new opportunities. And that's when I realized that perhaps I should have been better, I think, about how I was going to communicate, what I was thinking and feeling. And that's the thing that I guess I also will maybe give as a cautionary tale is that you might think you're okay, but thinking and doing are different things. And sometimes we do things that maybe we shouldn't. And sometimes we communicate more negative mindsets. They sort of say the unhappy married couple, the kids don't know because they go outside to fight, but the kids know. They
Right.
always know. And I wonder if that analogy has been ever been used about the unhappy physician, because you don't maybe want to say anything bad about your employer, or maybe you don't want to give out the impression that you're unhappy, but unless you're a really good actor, I think it's hard necessarily to know if you have frustrations. Of course, sometimes frustrations, can be just concern, but it can always be interpreted differently. Communication is often difficult and subject to misinterpretation, or how can I phrase it? Everyone has their own point of view, but not everyone's entitled to the facts. Uh,
Yeah.
but when you're dealing with a job, everyone will have their own opinion, and you want to be mindful of it. So I think that was a good point in which I was able to part ways, and that's sort of when I made my first push into more telemedicine. So it
Mm.
took me a while to get to the point, and there were some stops and starts along the way. This was probably circa 2018, I think, and it still was a very very new field in the sense that companies were getting going. There were certainly startups. There were some companies that had existed prior that were trying to do it by phone,
Mhm.
that really were trying to figure out the method to kind of make it functional. Still a lot of controversy, I think. Well, I should say controversy. Difference of opinion maybe is the better term. Can you do it only by phone? Do you need video? Do you need real-time video? Do you need a 4K connection, or can you get by with a lower resolution camera? And what is appropriate for telemedicine versus what maybe is not appropriate for telemedicine. And we think about it now, but I think certainly back 5 or so years ago, still a lot of questions to be answered. And I think every state also having very different ideas about their medical boards about how they wanted to manage telemedicine. I think was certainly a topic of great discussion. Some states, I think, probably needed more providers, so they were more open to it. Some states really were not terribly receptive to it. Some states, as you may know, the licensing process for different states can vary tremendously. Some are very expensive, some are not so expensive, some are very complicated, and some are not. So the lack, I guess, of any kind of standards is certainly difficult. It's changed a lot over the years since, but just going down that rabbit hole certainly uh, makes you realize, I guess, how far telemedicine has come in the last 5 years.
Yeah,
Um,
I think there was a lot of providers, medical providers, who were kind of tentative about it, and how does this really work, and can I do like some of the things you mentioned? And then the pandemic just kind of put everything into high gear, and we come out the other side, and I hear about synchronous and asynchronous visits and phone calls and video, and and then of course you got remote monitoring, which sometimes you can stick into the mix, but certainly totally different than it was 4 or 5 years ago now.
Yeah, and I guess I should specify. So I left that particular job, and that's when I sort of did more telemedicine. I also started to do a lot more locums in the area. More opportunities came up where I had never really done locums before. So the opportunity to leverage some connections I built up over the years to help cover some clinics, to help cover some maternity leave for some larger hospital systems, but also still going back and then sometimes then doing a couple hours shift telemedicine was an experience. And it went well enough that I kept doing the telemedicine for a while. And that's sort of when I got to experience both, I guess you can say, doing coverage physically in a clinic and then also doing telemedicine from home. And learned a lot. Certainly, this was actually still pre-pandemic. It was just before pandemic, and that was where things got really crazy, I guess you could say.
Yeah.
Only in the sense that I was doing a little bit of both. I was still sort of looking, experimenting. Do I want to open my own practice? Should I open up my own telemedicine practice? How can I manage this? And that's sort of when um, uh, just focused a lot on telemedicine for a period of time. And that's sort of when my locums assignments had sort of, run out. And I decided not to sign up for any more for a while so I could run more with the telemedicine component. And then I was doing that for a while. And I guess the one thing I learned is that, when you're in primary care and you have a patient coming in for a visit, it can be the first few minutes of the visit can be incredibly um, nerve-wracking because you don't know how sick the patient really is.
Mm-hmm.
And then when you see them on the camera, if you can, that's when you get an idea. Do I feel good about this? Do I not feel good about this? And maybe the major thing I learned was if you have concerns that the patient maybe is too sick for telemedicine, you have to be very explicit about that. And no, they'll never be happy to hear that. But if you're firm and you communicate your concerns, vast majority of patients that I explain my concerns to were willing to go into to an emergency room and get care, which was good. And I think you
Yeah.
have to be very cognizant of that if you're doing telemedicine because it's not the same as in-person care. And maybe that's the biggest difference is at least in in-person care, you can see the EMS take the patient to the hospital. But in
Right.
telemedicine, you have to sort of trust that they're going to follow through. And that was always I guess, a point of concern.
When people I've talked to, they seem to, indicate that's kind of the skill you need to know to recognize when they're sick and then to be able to quickly and effectively communicate, okay, this is not a telemedicine, visit. You need to see somebody, and whether it's emergent or in the next 6 hours or what have you. So yeah, that's okay. We're gonna run out of time pretty soon, so I really want to hear about the what you're doing now and how you feel that fits in with your long-term plans, and do you enjoy it? And I'd like to see
Yeah.
what you think about it.
So
It's
I
a
do
unique.
a
I don't know that many people are doing the job that you're doing now.
right. And I guess I'd say I'm from New York, so we talk a lot. So
It's all
kind of
right.
goes with the territory. As I was doing telemedicine, I did have some friends that were involved in doing more utilization management work. So I was able to pick up some extra work on the side. I cut to half-time telemedicine, half-time doing utilization management. This is more the traditional non-clinical job in which you're usually reviewing advanced imaging and
Hmm.
trying to make decisions about whether the MRI or the CAT scan should be approved. So did that for a while, and that experience, particularly working with different insurances and how to interpret rules and regulations, did give me the skills to connect with where I'm working now, which is more about reviewing Medicare claims as a qualified independent contractor. So working for one of the companies that reviews claims, it's quite complicated, much more complicated than I ever realized. But I guess what it boils down to is that Medicare rules and regulations are quite complicated. And even though I've worked in big hospital systems, even though I've worked in small startups, even though I've worked in many places, I did take quite a few Medicare, paying patients. The physician's knowledge of the intricacies of some of the regulations is maybe not what we thought. And then you kind of realize, well, everything's on the website. So if you really have a question about how to bill for XYZ, you can go to their website and look up, rules and regulations. And I guess maybe that's sort of the takeaway for me was I learned a lot through practice, although I did mainly outpatient, so I was probably more in part B than inpatient part A. But you sort of learn a lot by practice, and you don't necessarily, since we have separate billers and coders, maybe you don't get into the same level of detail that you do when you're actually reviewing the cases and you see
Hmm.
how it was coded, you see how the documentation was, and then you sort of see, you compare what you have to what the regulations for Medicare are, and you try to make sense of, why it was denied, what the rationale is. You do an independent review. You basically start from scratch to sort of see what your concerns are. But it certainly makes you realize just that obviously billing and coding for medical care is very complicated. And physicians really focus for obvious reasons on the clinical side. But looking back on how Medicare does their guidelines, how they do national coverage determinations, how they do local coverage determinations, all that information is out there. And if you do have patients you're taking care of, it's, I think, really important to be aware of how you do your documentation. That's probably why, clinical documentation, I guess, improvement specialist or clinical documentation review is also becoming a hot field because if we all had time, we could probably document to get better. If our computer system was better, we would document better. But you have to be the most efficient in the tools you have at hand.
Now, I have a
Uh,
question on the review of the Medicare. Was there much of a orientation or training? They just throw you some manuals. How did that work out?
oh no, I got some great doctors to work with that sat. We actually did it virtually because I had started the job right when COVID hit for real in March of 2020.
Hmm.
So that was when Seattle had its first few cases. Right before people finally realized that it finally had reached to the states, and certainly things changed a lot after that fact. Changes in telemedicine, and then changes with remote work. This was always a remote position,
Mm-hmm.
interestingly enough. So I was able to virtually sit, and of course now we have the technology to do this. Sit and talk by phone, by video, by real time text, sharing screens, going over cases, going over the information, trying to read through the major case types, understanding the types of cases you'll see in different parts of Medicare, whether it's Part A or Part B, understanding one's more inpatient, one's more outpatient, one has certain drugs are considered the B of A, so they fall under more of the Part A side. So getting a lot of minutia of detail and just understanding how the cases go. But a lot of really good doctors that have been doing this for a while and have a lot of experience were really helpful in getting me trained to pick up all these details. And then a lot of it, honestly, is also reading a lot of cases, reading the decisions and going back to the case and just looking through it back and forth and understanding, seeing the patterns arise. Why was this denied? Well, they didn't document XYZ. Well, why was this approved? Well, they did document XYZ. Sometimes it can come down to that. Sometimes it can be more of a judgment call, but document, I guess is what they say. And You want to be careful on what you put in the chart in the sense of, you know, just for certain conditions, you just need to be very explicit as to what you saw and document it. And if I guess it also comes back maybe strangely to the systems that we use. And if you EMR, as you said, whether it's due to time, energy, and money, is more out of the box. Maybe it's not as customized as it could be for your particular style or your clinic, and that could affect your reimbursement if it's not configured correctly to capture all the key things that you need. So it's kind of funny how that's kind of a circle, kind of a strange circle, and that we
Mm-hmm.
don't have time, so we kind of run through with our computer systems to document what we need, but maybe we don't spend enough time making sure it's documenting enough of the things we need, whether it's private insurance or commercial insurance or is it Medicaid, Medicare, because they do have requirements that are available for review, and we do want to be mindful of them because getting paid is important, and
For
not
sure.
getting paid for even the large health system can be quite onerous.
Yeah, it catches up with you if there's too much of that going on. Well, we are going to be out of time here in about a minute. So just looking back and maybe advice you have for other people that are kind of maybe they're at the beginning of the journey that you've made so far, where you're trying to find the right clinical thing to do, or maybe they want to do two different things, or maybe they don't want to do clinical. What advice would you have for people that just find themselves early in that process?
I think you do want to get at least some clinical basis. And when you're out of training, you want to practice for at least a few years. A lot of the best non-clinical work does often require anywhere from 3 to 5 years of actual practice experience. So for a lot of people, you might close some doors if you don't finish your residency, if you don't do, some clinical practice for a few years. But once you get through that point, that's a great time to reassess. And as I said, there's more and more opportunities, whether it's telemedicine, whether it's utilization management, whether it's clinical documentation improvement, whether it is doing case or claim review, whether it's legal consulting. There's tremendous, variety of things available. One of the struggles, I think, is just, connecting to figure out what's out there because it seems to change all the time. A lot of people didn't know about the work I'm doing now in terms of, review for Medicare claims. More were familiar with utilization management, and I think more getting familiar with certainly the legal consulting component, and also getting more familiar with the clinical documentation improvement. I guess that's maybe the flip side to what I do is that they're working with the docs to make sure they understand, if they're seeing case X all day long, that they know what the requirements are for documentation if they're billing a lot of Medicare claims. So that just that everything is set up, to set them up for success rather than uh, confusion and a lot of physician queries. That I see that that they send a query to the physician, the coder sends a query to the physician. What was this? And I remember getting them when I was practicing more in the traditional practice. And it's like, what is this? Why am I filling this out? And it's like, no, fill it out and try to actually think about what you're going to write because it's really important and it may actually affect whether you get paid or not.
Yeah, absolutely. I think some people might have, lingering questions that you've covered a lot of material here today. So it's okay, I assume, maybe if they can just find you on LinkedIn.
Oh yeah, absolutely. I'm kind of an
What'd you
open
say?
book.
David B. Weig?
David B. Feig.
Feig?
There aren't too many Feigs on LinkedIn. So if you see the doctor, that probably is me.
Pretty much nails it
There's a
down.
bunch of other ones I think are in other fields, but I don't think they have the middle initial. So
Yeah.
if you
Well, I
see
will put that
someone,
link in the show notes too. So if anyone's really struggling to find you, they can go to the show notes for this episode. So,
yeah, and if you see the one that went to Michigan for residency, that's probably me. So go blue. Hopefully, we'll bring home the big one for the playoffs this year.
all right, all of you out there, hope you are Michigan fans. All right, David, this has been really good. I appreciate it. We might have to have you come back in a few years and see if you're still doing this or have done something else. But we have a lot to think about. But I really enjoyed hearing your story today.
Sure.
So with that, I will say goodbye. I think David has faced the challenges that many of you are facing with respect to your careers. He described how our attitudes and feelings about each new job can shift from enthusiasm to burnout or at least indifference. And we heard his rationale behind the choices he made as he moved from traditional clinical practice to locums and telemedicine to his current non clinical job. If you have any follow up questions about any part of his journey, he's agreed that you can reach him on LinkedIn by searching for David Feig, Feig, MD, and that should take you to him. Also, I'll have a link to his LinkedIn profile and other related content, which can be found in the show notes at nonclinicalphysicians.com/find fulfillment and flexibility. Those are hyphenated. Now, let me tell you a quick reminder. If you're just starting your new career journey and want to learn how to pursue one of 10 popular non clinical careers, you can go to nonclinicalphysicians.com/free guide. And I'll send you my free 20-page guide. It's been downloaded by thousands of physicians just like you. Remember that today, this podcast is made possible by the support of the University of Tennessee Physician Executive MBU. MBA program. You can learn more about that at nonclinicalphysicians.com/physician MBA. Boy, I hope my editor catches that one. Some of the links I refer you to and that you'll find in the show notes are affiliate links. That means I receive a payment from the seller if you purchase the affiliate item using my link. Now, I don't have any affiliate. I don't think I have any affiliate links in today's episode or even in the show notes for that matter. I'll remind you that the opinions expressed here are mine and my guests. And while the information provided on the podcast is true and accurate to the best of my knowledge, there's no guarantee that using those methods will lead to success in your career, life, or business. So always consult, an attorney, accountant, or career strategist before making any major decisions about your career. Hope to see you next Tuesday. Right now, I'm planning to present my interview with a hospitalist leader who also serves as chief medical officer for a startup business that he co-founded. This should be pretty interesting. And you'll have to wait and see. So bye for now.